Okay, good evening, everybody. Hope you're having a nice summer and that you had a good Ganesh Chaturthi. Basically, some noise in the background. Can you guys mute your microphone? Okay, thank you. So can you hear me? Can you just reply and let me know that you can hear me? Yeah? Okay, fantastic. All right, so today's session is going to focus on syncope in children, and it'll be a case scenario-based discussion, so not particularly theoretical. But what we will aim to do is to cover the various aspects of syncope in the form of case discussions. Okay, so what you see on my title slide is a little goat that is fainted. So there is a syndrome in goats where when they're startled, they just dramatically faint. So there is a subtype of goats that is prone to this problem, similar to some of the humans. Similarly, in cats as well, this phenomenon has been noted. So it's not unique to us. There are other species who have syncopal problems as well. Okay. Okay. So scenario one. 1-year-old presents to A&E with a history of being unwell for the past 2 days with fever and poor oral intake. Okay. The morning, parents wake up, they find him unconscious with drooling at the mouth, and they bring him to A&E. On examination, he is not arousable, and his temperature is 40 degrees centigrade. So, what is the likely diagnosis? Is it syncope? Is it seizures? Is it some form of encephalopathy? What category does this clinical description fit into? Would this be syncope? Okay. Any of you think that this is syncope? Okay. So, see, this kind of an episode, is clearly not a syncopal episode. Okay. So we will deal with the definition of syncope in a couple of slides from now. But this clinical description clearly fits into either some form of meningoencephalitis or post-seizure state. So this is not just a plain and simple syncopal episode. There is something perhaps neurological or something more serious that is going on in this baby. Okay. So how would you define syncope? So what are the features of syncope? Can you just list out what are the features of syncope that are important in when you say syncope? What do you mean? You can just throw features, say for example, loss of consciousness, okay? And you can qualify that loss of consciousness. What kind of loss of consciousness? Is it a long-term loss of consciousness? Correct. So it is a sudden loss of consciousness, correct? It happens suddenly. How long does it last? Correct. So it's a transient, okay? So lasts only for a few minutes. It's a very brief loss of consciousness. And along with the loss of consciousness, you have a loss of tone, okay? So you just lose your postural tone and your consciousness, and it is usually sudden in onset, and it's a transient phenomenon, and usually with complete recovery. So these are the characteristics of what you would define as a syncopal episode. So complete loss of consciousness usually, because if you don't completely lose consciousness, it would be called pre-syncope. Okay, complete loss of consciousness, rapid onset and short duration. There's a loss of tone, and there is complete recovery at the end of it. So this is what defines syncope. And syncope is usually caused by a decrease in blood flow to the brain. Okay, that is the underlying kind of pathophysiology, which results in this clinical presentation. Okay, so just some ground kind of facts, just to lay the basis for the rest of the talk. It's fairly common syncope in children, and it happens in up to 50% of children. When you look at 0 to 18 years of age, up to 50 in that time span, up to 50% of children can have these syncopal episodes. Most of them are benign, and they are usually neurally mediated. Okay, we will come on to discuss the various types of syncope shortly, but most of them are due to autonomic dysregulation of some form. Okay, so they are usually benign and neurally mediated. Some of them are unexplained or perhaps related to some psychogenic problems. So very small proportion of syncopal episodes are actually serious or concerning episodes. Only about 5 to 10% are actually related to an underlying structural cardiac problem or a cardiac arrhythmia. So majority of the syncopal episodes are actually benign. And over time, they are self-limiting. So over time, children recover from these episodes. Okay. So now that we have kind of defined syncope, we have understood how common syncope is in children, and we know that majority of the times syncope is actually benign phenomenon. We then go on to discuss other patients with syncopal episodes to try and tease out what are the features that will make you think of pathological causes or important kind of causes of syncope, rather than just the benign usual vasovagal type of syncope. Okay. So the second scenario, 9-year-old is brought to clinic with a history of a fainting episode while standing in assembly at school. What is the most likely cause of this episode? It's a very typical history. This is something that all of us see in our outpatient. Correct. So the most common or most likely cause of this fainting episode is going to be neurocardiogenic or vasovagal syncope. So usually, it is related to decreased cerebral blood flow on standing up. There's pooling of blood in the lower extremities, and there is some malfunction in the usual response of the body to decreased blood volume. So normally when you have pooling of blood in the lower extremities and decreased intravascular volume, then what happens is that there is vasoconstriction, and this maintains your blood pressure. Okay, but when there is a malfunction in this mechanism in one way or the other, what happens is that the blood pressure is not maintained and it falls, and that results in decreased cerebral blood flow and therefore syncope. So the most likely cause is an autonomic syncope, which one of the important types of autonomic syncope is vasovagal syncope. So what are the questions you would like to ask these parents and this child? What are when any child presents with syncope, what are the various factors you would or pieces of information you would like to know? Come on, guys. Quick, tuck. Okay. Whether this is the first episode or whether there have been previous episodes. Okay. Right. When and where it happened. Okay. Duration of loss of consciousness. What else? That's right. So exertion is an important question to ask. Of course, all the other pieces of information are also important, but exertion, whether syncope was associated with exertion. So syncope associated with exertion is usually an ominous sign, and it should set your alarm bells ringing so that you start looking for serious pathology in this patient. So whether it was associated with exertion, what other information can you ask for? Okay, was it witnessed? What other associated symptoms can be there along with syncope, which would suggest some kind of cardiac etiology? Anybody? Chest pain. Okay. So for cardiac etiology, you're looking at chest pain or palpitations. Correct. So palpitations would suggest an underlying arrhythmia probably, and chest pain could point to some form of perhaps cardiac ischemia related to maybe a ventricular outflow tract lesion or a coronary abnormality, something that could be responsible for the syncopal episode. So exertion is important. Similarly, palpitation and chest pain is important. Then, of course, you ask for seizures, where there associated seizures. Was there anything to suggest a neurological cause of syncope? Because that would be your differential. If you were thinking of pathological, states resulting in syncope, one would be cardiac, and the other would be neurological. Reasons for syncope. So seizures or any residual neurological deficits. All of these are not typical of benign syncope. Okay, so these are important pieces of information to ask. Okay, so did the episode occur on exertion? Were there any trigger factors? So what are the possible trigger factors? It can be physical, like standing or being in a crowded place. It can be emotional, like stress. There is something called situational syncope, which comes on during certain specific actions like passing urine or swallowing. These trigger syncope. These are all forms of autonomic syncope. Okay. So, was there a postural change? From that is another. There is something called orthostatic syncope, where when the person gets up from sitting down, that's when they get the dizziness and loss of consciousness. And this can be associated with, perhaps a state of dehydration and hypovolemia. It can also be due to, associated with dysautonomia. Autonemia. So was there any associated postural change? Chest pain and palpitations we have gone through. Okay. Okay. What are the further questions that you would like to ask? So you have asked about the episode, whether the previous episodes. What other important information should you get? Any patient who comes to you with syncope, what are the other pieces of information you need? So you've asked about the presenting symptom. You've gone into detail into the episode per se. You also asked about previous episodes. What other history? Correct. So family history is very important in syncope. Okay. So you will ask for family history of similar episodes, family history of sudden cardiac death. So if you have sudden cardiac death in the family, that would raise your antennae, and your alarm bells should start ringing. You will start looking for specific conditions that are familiar. Then apart from that, what other history will you ask for? History of pre-existing cardiac conditions. Okay, so is this patient known to have a cardiac condition? Has there been history of a cardiac surgery perhaps? Of course, this is usually information that the patient will volunteer, but these are all important pieces of the history that you shouldn't forget. I think we've already touched upon this, neurological problems. Okay. And then, was there any injury? So sometimes patients who have syncope can sustain injury, even if it is just vasovagal syncope. Sometimes they can have minor injuries, but usually if the injury is quite significant, okay, if it is very serious injury, there is often an underlying, reason, pathological reason for it. Okay, so these we have already covered. Okay, so what further evaluation is required? So you've taken all this history. Now, what would you do next? How would you evaluate this patient? Okay, so patient comes in, you take history, you do ECG. Is that it? Absolutely. So where is your physical examination? So physical examination, what are the important things that you need to examine? BP. BP is good. What else along with the BP? Right. So heart rate, okay, because rate is important. The patient could be extremely bradycardic or tachycardic. Rhythm is important to determine whether there is some arrhythmia going on. Blood pressure. And what about the blood pressure will you be particularly looking at? What is specific, patient with syncope, what is specific about the way you look at the BP? What is a special thing you will do? Pulse pressure, okay. Maybe, but what you would do is measure the BP in supine position, correct, and standing position, because you're looking for orthostatic hypotension. Okay, so who can define orthostatic hypotension for me? What is the definition? What should be the degree of fall in BP? Correct. So systolic BP fall of more than 20 millimeters of mercury when you stand the patient up from supine. Okay, usually this will happen within a few minutes of standing the patient up. Okay, so right. So that is done. Postural hypotension, and of course cardiac evaluation. So cardiac evaluation, you will be looking mainly for listening to the heart sounds, and you would make sure, you will be listening for murmurs, which will suggest in this setting, if you had a murmur, what specific lesion could it suggest? That would result in syncope, correct. Left ventricular outflow tract obstruction, either a hypertrophic cardiomyopathy or a valvar aortic stenosis perhaps. So some form of left ventricular outflow tract obstruction is what you're looking for in this patient. Okay, then comes your ECG. Okay, usually this is the extent of evaluation that may be required. So if you have a pretty normal, cardiac evaluation with a normal ECG, this is as much as is recommended in the guidelines to assess a patient who presents with this kind of history, with a syncopal episode, which seems to be autonomically mediated. Okay, so there are no other warning signs. Seems like a simple faint, and this is all that's needed. Okay, occasionally when it's not very clear whether there's no postural hypotension, you're not entirely sure that, and perhaps this is not the first episode, it's troubling this patient, then tilt testing can be performed, and tilt testing will basically monitor the patient's heart rate and blood pressure from, they'll be laid flat and then they'll be tilted up, and then the heart rate and BP response will be determined, so that the exact autonomic response can be figured out. Okay, so in this particular patient, 9-year-old who's basically been in assembly in school and fainted, what would be your advice? How would you treat this patient? You've done an ECG, it's normal, your clinical examination is entirely normal. Often it is routine practice in a lot of units to do an echocardiogram as well, just as a baseline kind of thing. But I suppose if you have a completely unremarkable physical examination, one could argue that the echo is not required. Perhaps it can be done for the sake of completion. So all of these investigations are normal. What would you advise this patient? How would you treat? Right. So avoidance of exacerbating factors. Yeah. So reassurance is very important. Obviously, parents get very alarmed when their child faints. So you have to reassure them that this is a fairly common occurrence. So up to 50% of children have fainting episodes during their childhood. So it's a good statistic to kind of use to counsel patients. And increase the fluid intake and perhaps the salt intake. If there is very troublesome kind of syncope, then medications can also be tried. Beta blockers have been used and also fludrocortisone. However, the majority, more than 80 to 90% of patients have actually responded just to reassurance, fluids, and increased salt intake. Okay, so I don't jump to medical therapy very quickly. Most of the patients settle down with just the conservative line of treatment. Okay, so next we move on to scenario 3. So a 16-month-old baby brought to clinic with very distressed parents who report that the baby has had episodes of falling down and becoming unconscious, usually after hitting an obstacle. Okay, so the baby has just started to walk, so it's bumping into things, becomes very quiet, pale, falls to the ground, and then it kind of becomes unconscious, but recovers spontaneously within a minute or so. So what do you think is going on here? What do you think is going on here? Is this normal, or is this something that you would be very worried about? Okay, this is okay. It's a type of breath holding spell. Not really an atonic seizure. See, basically the child has these episodes of fall after hitting against something. Okay, so this is what is called a pallid breath holding spell, but actually it's otherwise called reflex anoxic seizure. Okay, so there is some kind of startle, either an injury or just a startle. And in response to this, there is vagal stimulation, which causes profound bradycardia. Okay, so the profound bradycardia then results in loss of consciousness, but this is usually self-limiting, and the child comes back. Now, if these episodes are kind of quite prolonged and the significant sinus causes, then some of these patients have required in some kind of interventional treatment, but majority of patients with time this settles down. So the reflex anoxic seizure is what it is. What is the underlying mechanism? It is a vagal stimulation. Okay, so how would you treat this if you have significant episodes? So usually reassurance is adequate, and usually the child, as the child grows older, this should improve. But if there are prolonged pauses, sinus pauses, what can help these patients? Anybody? Anybody? What can help these patients? You have huge pauses on the ECG. What can you do? So sometimes these patients, even though it seems like a very kind of benign phenomenon, they require pacemakers. So and their symptoms subside with pacemaker insertion. But this is only rarely required. But in patients with troublesome, these kind of attacks, reflex anoxic seizures, sometimes they require pacemakers. So this is also known as a pallid breath holding spell. There is the other breath holding spell, which you see often in toddlers who cry and kind of develop an abnormal breathing pattern, then stop breathing. Right? They become blue and they become cyanosed and can become unconscious as a consequence of that, or floppy. That is called a blue or a cyanotic breath holding spell, and this is a pallid breath holding spell, which is an injury which causes vagal stimulation and bradycardia with asystole, which then recovers spontaneously. So this is not really a pathological phenomenon. It's just an abnormal response to a traumatic stimulus. So an ECG is the basic investigation you would carry out just to rule out any abnormalities, significant abnormalities. Sometimes it has been noted that these patients respond to iron therapy. Okay, So a CBC to look at the hemoglobin is useful, and perhaps 3 months of iron therapy has been shown to have some beneficial effect in some of these patients. Okay, so this is something that you see mainly in the younger age group. Okay, pacing, like I mentioned, is only rarely required. Okay. Excuse me. Okay, so now we go on to scenario 4. 12-year-old is brought to emergency from his school by his parents, because the school has called the parents saying that the child has had an episode of loss of consciousness. Okay, so what are the questions that you would like to ask? Now the child is recovered, so they laid him flat and then sprinkled some water on his face. And after a while, he recovered. Excuse me. Okay, so the important thing is to know. Okay, duration of unconsciousness is important. Trigger factors. So what was he doing when it happened? Okay, so was he sat in class? Was he in an assembly standing up, or was there any exertion involved? And of course, like we did with the previous patient, you go through all the features in the history. So what was he doing when it happened? Was it associated with exertion? Was there any change in posture? So if this child had been, say, unwell, had diarrhea and vomiting at home, had come to school because there were exams coming up, so he may be dehydrated, in which case the standing up can make him dizzy. So it's important to get all the history is the most important feature in syncope. Okay, taking a detailed history and making sure that all the various aspects of the history are covered. So were there any prodromal symptoms or associated symptoms? Okay, was there any chest pain? Was there any palpitations? In patients who have vasovagal syncope, they often have nausea, a nauseous feeling. They may have some, kind of sweating, some mild visual disturbances. So they can have these prodromal features. So that's typical of vasovagal syncope. Obviously, associated symptoms here, you want to know about chest pain and palpitations and seizures. Okay, and then the usual history of family history and previous medical cardiac history. So on questioning the parents, apparently the episode happened during PE class while he was playing football, and he experienced some chest pain prior to the episode, but currently he seems symptom free. So what do you think of this piece of information? Is this something to be worried about? Is this something to be worried about? He was playing football when it happened. He had some, yes. So he had some chest pain and then had syncope when he was exerting himself. So what does that kind of indicate? This history, what does it suggest? Yeah, cardiac etiology, correct. And perhaps some left ventricular outflow tract obstruction. Or a coronary problem that is presenting in this fashion. So that would raise your suspicions, and you'd want to make sure that everything was okay. So this is cardiac syncope. Okay. So now that you have this history, of course, you would want to examine the patient. So you would want to know the usual heart rate, blood pressure, and listen for any murmurs. Okay. So what are the investigations that you would carry out on this patient? So you have done your physical examination, and now you've come to the stage of investigation. What are the investigations that you would ECG? So ECG would give you left ventricular hypertrophy and also strain. Then echo will tell you if there's any structural problem like aortic stenosis or HOCM. Okay. ECG, echo, And then based on these findings, you will decide on what you want to do further. So if you have a baseline ECG with LVH and strain pattern, and you have an echocardiogram which has significant LVOT obstruction, then perhaps, that is enough information. Knowing that this patient has had a syncopal episode on exercise, you would not exercise this patient. You wouldn't put him on a treadmill test necessarily, okay? So it's plus minus treadmill testing based on what you find on your ECG and echo, and plus minus Holter monitoring, depending on what you find with your basic investigations. Okay, so this is the ECG that you've got. Is it normal? What's happening in this ECG? What can you see? No answers. Correct. So there are voltage criteria for LVH is satisfied, and more importantly, what's going on here? What is this? Correct. So this is T-wave inversion with LVH, signifying that there is left ventricular strain pattern. Okay. So the ECG, kind of confirms your clinical suspicion that there is a problem, and this is his ECG. Echocardiogram. So what has he got? The spot diagnosis, obviously. So what are we seeing here? Correct. So it's hypertrophic, most likely obstructive cardiomyopathy. Okay. In patients with HCM, what are the mechanisms by which syncope can happen? What are the reasons for syncope in a patient with HCM? Come on, guys. Correct. So one is the left ventricular outflow tract obstruction. So if you have significant left ventricular outflow tract obstruction, obviously you cannot raise your cardiac output, particularly if you have sudden vasodilatation, then it's a fixed cardiac output type of scenario. Okay. What are the other problems that patients with HCM can have? Okay, compression of coronary is what is the other problem they have? Even if they don't have significant this degree of arrhythmia, yes. So they can have ventricular arrhythmias. So that can also result in syncope. So it can either be a mechanical problem or it can be an electrical problem. Okay, but here there is a significant gradient. So the peak gradient is about 110. It's a significant gradient, and there's a clear, kind of dynamic component to that trace. Okay, so what next? So would you exercise this patient? Would you exercise this patient? Yeah. So no. So because you know that he's already had symptoms of syncope on exertion. You have clear-cut evidence of LVH and LV strain with significant outflow tract obstruction. This would not be a good patient to put on the treadmill. Okay, so in this situation, there is no ambiguity. Now you know that the reason for the syncope, which is most likely mechanical, but what is worthwhile perhaps doing is a Holter. Okay, and this would be to look for any ventricular tachycardias or any arrhythmias that are subclinical to see how prone he is to having arrhythmia. So probably worthwhile doing a Holter, but definitely not a treadmill. Okay, so treatment, of course, you guys know, alcohol ablation or septal myomectomy. Of course, counseling and family screening very, very important, because other members of the family may also be affected. So it's quite a bad diagnosis for both the patient and the family. So these would be the kind of steps of management. Okay. So next patient, 6-year-old, okay, presents with a history of recurrent sudden falls over the last 6 months. Initially, the parents thought the child was just clumsy, but the last episode resulted in a significant fall and a cut over the forehead, okay, requiring some sutures. Okay. So what do you think? So these are significant sudden falls. And it's a relatively young child. So slightly on the younger side for a vasovagal syncope type episode, and fall associated with significant injury. Just listening to this, would you be slightly concerned? Yeah, so important to know, yes, could this be atonic seizures? So it's an important thing to evaluate. Then you question as per your usual history taking. On further questioning, there was no specific trigger of the episode and no specific association with exertion. Okay, that's a relatively small child, so a little difficult to have significant exertion. There's no history of seizure-like activity. So other important history to ask for is your family history. Okay, there is no underlying cardiac disease in this child or history of cardiac surgery. But when you ask about family history, parents report that their first child died suddenly at the age of 2 years of an unknown cause. So they really didn't find out what the underlying cause was. It was just one episode of, just sudden death, basically. And there had been no episodes of faints or, any warning before that. So is this something to take note of? Is this something that would worry you? Yeah. So what are you thinking when you hear the whole story? What are the things that come to your mind, top of your mind? Sudden death? Correct, yeah. Yeah. So, like somebody suggested, long QT syndrome. This is a very, very typical history of long QT syndrome. And in fact, this is one of my patients. So, important investigation to carry out in this situation would be an ECG. Okay. So, the important features on the ECG, of course, are prolonged QT. Okay. You can see here that the QTC is prolonged. Not only that, the T wave is very abnormal. Okay, so this is also a clue. So when you see abnormal T waves like this, it should definitely raise your suspicion of long QT syndrome. Okay, so this child had long QT syndrome, only 6 years of age, had lost a sibling to sudden cardiac death, and was having multiple episodes in the last 6 months. So, and we can see that the ECG is clearly abnormal with a prolonged QT interval of nearly 500 milliseconds and abnormal T waves. Okay, so how would you treat? Obviously, there are certain trigger factors to long QT syndrome. They can be auditory, they can be things like swimming, diving, etc. Depending on the type of long QT syndrome. You can carry out genetic testing in these patients, but as far as treatment is concerned, there are only two, treatment modalities. One would be beta blockers, and the other would be ICDs. Okay. Now, with the history of cardiac death in the family, this child would be in a high-risk category and would actually qualify for an ICD. But the child is only 6 years of age, so an ICD has its own problems at this age, and it's not easy, an easy matter. So perhaps pragmatically you would explain and counsel the family, and then start the child on beta blocker to see if you're able to, control these episodes. Often it may be useful to do a Holter pre and then a Holter post, but I suppose the symptoms will also guide you. So if you start beta blockade and then the syncopal episode stop, that is a good sign for you. But I think if you have a patient who presents to you with this kind of history of sudden episodes, you would pretty much want to get in there and treat straight away rather than wait for all your extensive monitoring. Or you would admit in hospital if from clinic, do the Holter, and then perhaps initiate the beta blocker. But I would want this patient on treatment pretty much straight away because the risk of sudden cardiac death in this patient is pretty high. Okay. Okay, so let's just briefly discuss the classification of syncope. There are multiple classifications. This is just one of them. So broadly, you can classify syncope into autonomic syncope, which is further subclassified, okay, into conditions which create orthostatic intolerance. Under that, you have vasovagal syncope, orthostatic syncope, and then postural orthostatic tachycardia syndrome. Here, this is something that's more common in women, and what happens is there is a inappropriate tachycardia when the posture is changed. So supine to upright, there is an inappropriate tachycardia. So this is a finding on tilt testing that is that is seen. So that's one form of orthostatic syncope, which is one form of autonomic syncope. Then you have the situational syncope, which we discussed earlier, associated with either swallowing or micturition, some specific act. So these are the more benign syncopes, right? Orthostatic intolerance and situational. Neurocardiogenic or vasovagal, is a typical syncopal episode that we see in our teenagers and adolescents, and this is because of the fact that vasomotor tone is not maintained. So normally, like I explained to you, when somebody stands up, what happens is that there is vasoconstriction. But when this doesn't happen, then there is a drop in the BP and drop in the cerebral blood flow and syncope. Okay, orthostatic hypotension, orthostatic syncope is associated with certain conditions like diabetes because of the neurological abnormalities. So here it's a similar autonomic dysfunction, but all of these are autonomic syncopes. Then of course you have cardiac arrhythmic syncope. We've already seen long QT as an example of that. Okay, so long QT results in ventricular tachycardia or ventricular fibrillation, and this can result in syncope because of inadequate cardiac output. There are other causes of ventricular arrhythmias. We'll touch upon them as we go forward. Okay. In cardiac mechanical syncope, we saw an example of that in the hypertrophic obstructive cardiomyopathy. Other conditions include aortic stenosis, severe mitral stenosis, etc. Once again, we'll discuss this in our later slides. Then, of course, you have the neurological and psychiatric, and finally metabolic, things like hypoglycemia, etc. So these are the various classifications of syncope, often based on the underlying pathology or cause. So this we have already discussed. So these are the usual prodromal symptoms associated with vasovagal syncope: nausea, sweating, visual haziness, lightheadedness, and usually this is associated with postural change. So how would you work up a patient who presents with syncope? Important thing is history, then examination, which includes a blood pressure measurement both in supine and standing position, and of course an ECG. Now if the history is clearly suggestive of a neurocardiogenic type of phenomenon and your ECG is normal, then you don't need to do anything further apart from reassurance and treatment in the extreme cases. If the history is not so convincing, there are some warning features. For example, you have palpitations or chest pain, other features suggesting that there may be an underlying cardiac problem. Patient undergoes an echo, perhaps an exercise tolerance test, and then depending on the results, suppose the echo shows you something, then you treat the condition. If the tests are negative, then if it is a single episode, benign episode, then you just wait and watch. If they are recurrent episodes, but they are frequent, then you can do a Holter monitor. So if it happens, say, every alternate day or something, you can do a 48-hour Holter or a week-long Holter. Or you can use an event recorder. If it is something that happens very infrequently, happens only once in 6 months, etc., there are implantable loop recorders which you can implant subcutaneously, and these will record events, as they happen. So, and they can be read off when the patient comes to OP. So this is a broad flow chart of how you can work up a patient with syncope. But a point to note is the majority of patients will not need any of this. Okay, most of them will fall into this category. At the most, they may fall into this category. Okay, so the small subset of patients who need further monitoring and long-term loop recorders. Okay. So next we come to our next scenario. A 17-year-old patient, slightly older child, almost an adult, who's known to have CHD, presents to A&E with a 24-hour history of palpitations. So he's waiting, sitting in the A&E, and then, when he's called to come to the examination room, gets up from the chair and collapses right there and loses consciousness. So immediately the entire team gets into action. So they kind of raise his legs up and start kind of doing things to make sure he's okay. But as soon as he's laid flat and his legs are raised, he recovers consciousness quickly. Okay. You look through his records and you find out he's undergone Senning's procedure for TGA at the age of 3. So what will you do now? So if you go back, he has a 24-hour history of palpitations, correct. So the first thing you will do, of course, is your basic resuscitation. You make sure that he is actually stable. You would put him on a monitor, definitely check his blood pressure, okay. Give him oxygen if you think he would benefit from it, and then do an ECG. Okay, so what is the likely cause of the syncopal episode? Somebody has already answered that. Someone's come up with SVT. Yes. So patients with Senning are more prone to atrial arrhythmia. So this could be some form of atrial arrhythmia, but he could also have ventricular arrhythmia. So the most likely cause of the syncopal episode is arrhythmia. Could be most likely atrial, but also possibly ventricular. Okay. So then his ECG is done. His heart rate is quite high. It's about 200 per minute on his ECG. And then you get this tracing. What has been done here? Correct. So adenosine has been administered. So and then you see that it has created AV block, but the underlying atrial activity has been unmasked, and the atria are going at about 200 per minute, which is pretty high for an adult. So this patient appears to be in atrial flutter. So what would you do? How would you treat him? So he's a person who's had a Senning operation. He gives at least a 24-hour history of palpitations, and you find that he has atrial flutter. How would you treat him? What does he need? Okay. So why not cardiovert him? Why would you not cardiovert him? Yeah. See, flutter can respond quite well to cardioversion, and your antiarrhythmics do have significant side effects. So I would be in favor of cardioverting him because flutter is particularly a specific type of SVT that on cardioversion reverts back to normal sinus rhythm in a lot of patients, the majority of patients. So first line of treatment would be cardioversion in this patient. Okay, irrespective of the hemodynamics, I would cardiovert him because his underlying rhythm is flutter. Okay, but before cardioversion, the important thing is to ensure that he doesn't have any intracardiac thrombi. So he needs a good echocardiogram, perhaps even a transesophageal echocardiogram if he's relatively stable. and will tolerate a TE. Probably a TE to rule out an intraatrial thrombus is a good thing. Of course, if he is an extremist and that's not possible, then just a transthoracic echo, and then perhaps cover him with intravenous heparin. Okay, so he will need IV heparin anyway to cover him, irrespective of whether you can see a clot or not. Okay, patients who have long-standing flutter, because you don't know with him whether how long the duration of his flutter is. Is it only 24 hours, or do you think it may have preceded it? In patients who are very stable, sometimes they can be anticoagulated with warfarin, and then you can cardiovert them. But particularly in this situation when he's obviously got postural hypotension, so his baseline BP is likely to be borderline. So he needs to be brought back to sinus rhythm as quickly as possible. So here you give IV heparin and you also cardiovert him. It's possible TE him before this. And what long-term therapy would you put him on? You would start him on an antiarrhythmic like you guys suggested, which various antiarrhythmics can be used. Something like a class 3 agent like sotalol might work quite well. Amiodarone is another option. Anticoagulation, that is particularly if you expect that he may, with his underlying anatomy, is likely to go into flutter again and again. And anticoagulation is quite important to prevent thromboembolic events. After cardioversion, patients should be continued on anticoagulation. You give IV heparin and then you start them on warfarin, and they should be on it, for at least 4 weeks. But long-term therapy, I would probably continue this patient on long-term anticoagulation. Perhaps if he stays in sinus rhythm on monitoring later on, we can consider taking him off it if it's creating a huge problem in terms of his quality of life. But when he presents to you with flutter and you've cardioverted him and you know his underlying anatomy is such that he is likely to go back into flutter, till his antiarrhythmic medication kicks in and perhaps maintains him in sinus rhythm, I would keep him on anticoagulation. The other treatment modality obviously is ablation. So with all this carto mapping that is possible, even in complex patients like these, it is possible to ablate the flutter pathways. So this would be your treatment strategy. Okay, so post-Senning operation, what are the other electrical disturbances that can cause syncope? So one thing we talked about is, yeah, correct. So sinus node dysfunction is the other thing. So huge sinus pauses. So for that, what would be your treatment? If you have significant sinus node dysfunction and sinus pauses, yes, pacemaker. Okay, that's one. Then what else? Think slightly out of the box. MIOT we have already mentioned. Correct, heart block. And this would be particularly in the setting of a double switch. When you have a Senning along with an arterial switch in patients with CTGA who are prone to heart block can also happen. And these patients also will need TACER. Okay, so the next scenario. Okay, a 10-year-old presents with a history of recurrent episodes of syncope over the last 6 months. The parents describe in addition easy fatigability and inability to keep up with his peers. So he's getting tired very easily, low exercise tolerance and recurrent episodes of syncope. Okay. So what are the possible things running through your mind? Yes, left ventricular outflow tract obstruction is one of the possibilities. There is no, something like DCM, some myocardial dysfunction, which has resulted in a low cardiac output state. There is no history of palpitations or chest pain in this patient. Only history is easy fatigability and syncope. Okay, so but these are two possible causes. That there is a mechanical obstruction, that there is myocardial dysfunction with low reduced cardiac output. Okay, that is definitely something to consider, but probably last on your list, right? So you'll try and rule out the important pathological causes, and then this will probably go further down the list. Okay, so let's go further. So it could still be vasovagal syncope. It's the most common kind of form of syncope. Okay, so it still could be vasovagal syncope, and then of course could be cardiac syncope, like we discussed, or psychogenic, like you pointed out. So you examine him. Child is stable, and clinically looks well. Heart rate is 45 per minute, good volume. The soft ejection systolic murmur. What are the striking features on this clinical examination that you have done? What strikes you? Correct. So this child appears to be bradycardic. Okay, so there's significant bradycardia, and obviously the next step for you to find out, is why is the child bradycardic? Okay, so you would want to do an ECG. Okay. So what investigation would you order? An ECG. So let's see what the ECG show. So what does the ECG show? So what is the underlying cardiac rhythm here? Correct. So this patient has got complete heart block. So often this is likely to be congenital complete heart block, which has been undetected, and it's still quite common to find patients like this who present at a much later stage with incidental bradycardia and heart block. And because obviously of the low heart rate, there can be episodes of syncope. So usually when a patient has complete heart block and syncope, this is an indication for a pacemaker. So no doubts about it, this patient will need a pacemaker, and hopefully the symptoms will improve with that. Okay. So now supposing this child had sinus bradycardia, okay, with a heart rate of 45, what is the other test you would do? What is the test you would do? Significant bradycardia, but sinus. What are the two things you should do actually? One is to determine if this is a treatable, okay, TMT, okay. I think there are more important investigations in a TMT. And this TMT is not on my list actually. But yeah, it could be done, but further down the line. So a child presenting with a heart rate of 45, sinus bradycardia. As a pediatrician, what would you do? As a pediatrician, what would you do? Thyroid function test. Wouldn't you do a thyroid function test? Yes. So, patients who are significantly hypothyroid can present with bradycardia. And if it's sinus bradycardia, profound sinus bradycardia, first test to do is by TFT. Okay, this is to rule out a treatable cause of this bradycardia. Then a Holter is required. Why do we do the Holter? To see if there are any significant pauses. So if you have a significant pause that could be life-threatening, then that could potentially change the way you treat this bradycardia. So these would be the two very important tests to do. Of course, an echo is to ensure that this is a structurally normal heart. TMT will tell you if this heart rate increases on exercise, which is also useful because then if it does increase with exercise, you are more reassured. Okay, but important thing if you have a patient with profound sinus bradycardia is to do a thyroid function test. Very important, not to be missed. Okay, so I promised that we would discuss the cardiac mechanical causes to consider in patients with syncope. So we have already touched upon left ventricular outflow tract obstruction. These are mechanical or structural kind of causes. So we talked about LVOT obstruction. Okay, we talked about severe mitral stenosis. So these would be the left-sided obstructions that could result in syncope. So similarly, on the right side, you can have severe pulmonary stenosis that can limit the cardiac output. Okay, you can have a pulmonary embolus. So you have a massive pulmonary embolus that can also limit the cardiac output by blocking the pulmonary artery. What is the other situation which we see in pediatric cardiology practice? Syncope. What other condition do we find this? Say, for example, let me say untreated cardiac disease, congenital cardiac disease. Untreated, say an untreated. Anybody? Correct, PAH. So syncope can occur in patients with pulmonary hypertension, but it tends to occur more often in patients with idiopathic pulmonary hypertension because they don't have a shunt. Okay, the untreated was just a clue so that you come to pulmonary hypertension. Actually, in patients who have, say, a left-right shunt, which is then Eisenmengeri's, these patients tend to have a lower incidence of syncopal episodes, which are, kind of so-called life-threatening syncopal episodes. Whereas in patients with idiopathic pulmonary hypertension, they can have pulmonary hypertensive crises where there is, a drastic reduction in cardiac output, and there is no possibility of a shunt to maintain the cardiac output. So patients with idiopathic primary pulmonary hypertension are the ones who are at risk of life-threatening syncope. Okay, so this is another subgroup who can present with, who have cardiac mechanical causes of syncope. Of course, there is the functional group, which is dilated cardiomyopathy or some coronary artery-related condition. Okay, so let's just make sure we've covered everything. LA myxoma, don't see it in children much, mainly in adults. So the severe PAH we talked about. Tamponade is the other possibility. A severe tamponade, massive pericardial effusion, can limit your cardiac output and produce syncope. Okay, then we go on to the cardiac electrical causes. So you have, channelopathies like long QT syndrome, short QT syndrome, we have Brugada syndrome, and there is this condition called catechol-aminergic DT, which is particularly sensitive to exercise. Okay, so even minor exercise, it's an autosomal dominant condition, if I'm not mistaken. You need to cross-check that. But what happens is that it runs in families. Even minor exercise can precipitate VT, and this can result in sudden cardiac events. So that's important. These patients are usually treated with nadolol, beta blocked, and then exercised after beta blocker to make sure that they don't have any such episodes. Okay, so you have all these various channelopathy type conditions, and you have complete heart block, and you have sinoatrial node dysfunction. These are all the various electrical possibilities or causes of syncope. You can also have syncope in the pre-excitation syndromes. I haven't mentioned that here. So pre-excitation syndromes or SVT type situations, atrial arrhythmias, and pre-excitation syndromes can also cause syncope. Okay, so this is just a spotter ECG. So can anybody identify the condition here? Correct. So this is a typical ECG of a Brugada syndrome patient. So you have, usually these changes are seen in V1 and V2, the right side precordial leads, the so-called coving of the ST segment, and an inversion of the T wave. So it's a coving of the ST segment. So that is Brugada syndrome. Usually this is treated by means of an ICD. Okay, ICD implantation is the treatment. Okay, so if you look at outcomes, there are papers, published on adult data, and in children, there are only limited and small studies. Okay, so let's just kind of go through the adult data first, and then discuss what the situation in children is. So usually in the adults, syncope of unknown cause, where you don't have a cause, there's no underlying cardiac problem, you assess the patient, there's no cause. Usually that has a good prognosis. So there's a low incidence sudden cardiac death, and there is a chance of recurrence, but there are no significant adverse events, or the incidence of significant adverse events is very low. Most of them go into remission. Now, the rate of recurrence seems to be slightly higher in children, which we saw, just from the data. Children tend to have more episodes of this, syncope. Once they've had one episode, there's a greater likelihood they could have another one. In adults, syncope with cardiac problem has a poor prognosis. So there's in the first year after the diagnosis, in 1 year, there's a 20 to 30% chance of sudden cardiac death. And if they are in NYHA 3 or 4, there's a 25% mortality in the first year. So definitely the underlying etiology or cause of the syncope has a profound impact on the prognosis. It's quite similar in children as well. But of course, the outcome depends very much on the underlying cause. For example, if you have a child with complete heart block who has a syncopal episode, there is an underlying cardiac problem, but it's a treatable cardiac problem. So you can pace this patient and they will then go on to live many years. So, the outcomes are variable depending on the underlying cardiac pathology. In the adults, obviously, majority of them have MI or heart failure. So it's just ischemic heart disease related problems, majority of them, or perhaps HCM, but small proportion. So whereas in the children, very diverse group of patients having syncope. But the good news is most of pediatric syncope is benign. Okay, up to 90% of them don't have any serious underlying problem. So it's only a small proportion that actually have a real cardiac or a neurological problem. So majority of them can be treated purely with reassurance or conservative measures. Okay, so that kind of brings me to the end of my talk. If there are any questions that I can answer, I can take them now. Anybody?